Dear colleagues, in partnership with the Société Francophone de Nephrologie Dialyse Transplantation, the Österreichische Gesellschaft für Nephrologie and the Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomed Professor Nassim Kamar on our Tour Académique from Italy to the Côte d'Azur in Toulouse, France, the capital of the Région d'Occitanie, host of this weekend's stages of the Tour de France, in order to learn what nephrologists should know about hepatitis E. Dear Nassim, we are very happy to have you back on our channel, almost exactly 3 years after your first visit. Thanks for taking the time.
It's really a great pleasure to welcome Nassim Kamar today for this conference. Nassim is one of the most dynamic nephrologists in France regarding kidney transplantation. He's done numerous works on different viruses, especially hepatitis E. He's co-authored more than 600 publications altogether today, and more than 200 of these publications are on hepatitis, especially in kidney transplant recipients. He's been co-author of KDIGO guidelines on hepatitis C and CKD patients recently, and now it's our great pleasure to listen to you, Nassim, on hepatitis E in kidney transplant patients. Thank you very much.
Thank you very much to both of you. Thank you very much, Dominique, for the very kind invitation. I'm really very happy to be here and to try to give you some insight on what should the nephrologist know about hepatitis E virus. As you already said, it's one of my favorite viruses. So, hepatitis E virus infection, it's an old story. It started nearly in the 1950s, and it was responsible for pandemics in developing countries, especially in India. And it's an hepatitis that's responsible for self-limiting infections, and the main symptom was jaundice. And until very recently, it was considered that in our country that it's only a travel-acquired infection, and it was underdiagnosed due to the lack of robust assays. And currently, it's the most prevalent viral hepatitis worldwide. The HEV virus is an RNA virus. There is one serotype and 4 main genotypes. There are several genotypes. The 4 main genotypes are genotype 1 and 2. And genotype 1 and 2 are especially present in the Asia and in Africa, and it's HEV1 and 2 are transmitted via an oral fecal route. However, in our developed countries, especially in Europe and in the US or in South America, we can find genotype 3 and 4, especially genotype 3. Genotype 4 is more prevalent in China. And it's a zoonosis because the reservoir is animals, and it is transmitted from animals to man. So what are the main routes of HEV3 and 4 transmission? We will focus on HEV3 and 4 since they are the main HEV that we can find in our countries. The main route is the eating undercooked meat. As I said earlier, the main reservoir for the HEV are animals, especially pork, deers, and eating undercooked meat can be responsible for HEV infection. And since HEV is released by the feces of the animals, it can contaminate the water, and irrigating shellfish and crops, and even eating some crops, shellfish, and some vegetables can be a source of infection for HEV. Another way of transmission is a direct infection from man to man. Several cases have been published, especially in some dialysis unit on one hematology ward. If the patient are contaminated in the same room, you can have a direct transmission from man to man. The direct infection from animal to man can exist, but probably there are very few cases. Another important mode of transmission is the transmission by blood products. Indeed, until very recently, we were not looking for HEV in the blood. And finally, if you look on the right part of the slide, you can see that HEV RNA can be detected in 1 out of 2,000 blood donors. So we can find it in several blood products. Several cases have been already published, especially in transplant patients. You can see that you have some cases in some heart, some liver, and some kidney transplant patients. And there's also some transmission of HEV by the plasma exchange, by infusion of plasma to the patients. So this is one of the main causes, one of the causes of transmission. It's probably around 10% of the transmissions. So in several countries, including in France, there's a systematic screening of all blood products for HEV. So it becomes absolutely mandatory to do it. Another way of transmission that we can consider may be the transmission by organ transplantation. Indeed, there are some few cases published in the literature, a transmission by a liver transplantation or transmission by a kidney transplantation. And we had looked several years ago for organ donors, and we did not find HEV RNA in our population. However, since January 2024, it became mandatory to screen all organ donors for HEV RNA. You can graft the kidney, but you have to keep in mind that you may transmit the virus. And it's already the case already in the UK. And another important point that all patients presenting with increased LFTs should be screened for HEV. And how should we screen the patient? We can screen the patient and doing the serology, and especially for looking for HEV RNA in the blood and in the feces. For some research purposes, you can also look for the HEV antigen. So when you are infected by HEV, first you have HEV RNA in the blood, and you have a small window between where HEV RNA is undetectable in the blood, but it's still detectable in the feces. So if you are suspecting HEV infection, you have to look for both in the blood and in the feces. What about the serology? This is an organigram that we did several years ago. In immunocompetent patients, you can rely on IgM. If the IgM is positive, you are quite sure that the patient is infected by HEV, and you can confirm it by looking for HEV RNA. However, in immunocompromised patients, especially in transplant patients, it will be the second part of my talk, you may have some negative IgM patient, but still HEV RNA positive. So if the IgM is positive, you can confirm it by HEV RNA, but if it's negative, you can go directly to HEV RNA. So this is why in immunocompromised patients, the recommendations are to look for both HEV RNA and to look also for the serology. What is the natural history of HEV infection? We can split it in two parts, genotype 1 and genotype 3 and 4, the one that are present in our countries. Overall, for genotype 1, nearly 3.4 million symptomatic cases per year. For genotype 3 and 4, it's absolutely unknown. Genotype 1 infection occur more often in young adults, while the second 3 and 4 occurs more often in elderly males. 20% of genotype 1 infection are symptomatic, but less than 5% of genotype 3 and 4 are symptomatic. The majority of the patients are not symptomatic, and you have just to look for HEV. When you have an increased LFTs, you look for HEV RNA and you found that it's positive. Genotype 1 do not evolve to chronic hepatitis. There is no cases of chronic HEV infection reported with genotype 1 infection. Conversely, as you'll see later on, genotype 3 and 4 can be responsible for chronic hepatitis in all immunosuppressed patients. What about acute liver failure or acute on chronic liver failure? For genotype 1, it's responsible for a very high mortality, especially in pregnant women infected by HEV, up to 25% of mortality for the woman and for the child. No deaths in pregnancy for genotype 3 and 4. In cases of acute on chronic, for genotype 1, very high mortality. There is an increased mortality with genotype 3 and 4, but not as high as for the other one. And finally, we do not know what's the overall mortality rate for genotype 3 and 4. So until 2008, it was considered to be responsible for an infection that is a resultant infection. However, we have reported for the first time in 2008 the first cases of chronic HEV infection that occurred among organ transplant recipients. And thereafter, several cases have been reported in SOT patients and HIV patients, hematological patients, and stem cell transplant patients, and all patients receiving any immunosuppression. The definition of chronic HIV infection is probably the persistence of HIV RNA for more than 3 months. The natural history of HIV infection among solid organ transplantation looks like this. This is a retrospective European study that we had performed several years ago. And among 85 patients who had a follow-up of more than 6 months, 1/3 of the patients have a spontaneous clearance of the virus, while 2/3 of the patients evolved to chronic hepatitis. And the most striking information in the study was that nearly 10% evolved to cirrhosis. And the time between the diagnosis and the cirrhosis was very short, because it was 2 to 3 years, which is much more aggressive than HCV or HBV infection. In addition to the liver disease, it can be responsible for neurological diseases, manifestations, especially Guillain-Barré syndrome, neuralgic amyotrophy, but it can also be responsible for kidney injury, and this is what the nephrologist should know. It can be responsible for MPGN or membranous nephritis. I'll go through this data in the next slide. Neurological manifestation and kidney injury are really associated with HCV. There's a real relationship. With the other manifestation, pancreatitis, myocarditis, and others, they have been observed in patients with hepatitis C, but we did not find a robust relationship between both. With respect to neurological symptoms, you can see very rapidly that it occurs worldwide, whatever the genotype is, and the main manifestation is Guillain-Barré syndrome. There are some very nice studies from Belgium and from the Netherlands showing the real relationship between HEV and Guillain-Barré syndrome, and similarly with neuralgic amyotrophy. What about the kidney? Few years ago, more than 10 years ago now, we did a retrospective study and we looked for HEV amongst 51 solid organ transplant patients. And among these patients, 1/3 have resolving hepatitis and 2/3 evolved to chronic hepatitis. And we looked what happened for kidney function. First of all, we observed that in patients with resolving hepatitis and chronic hepatitis, there's an impairment of kidney function at the time of the infection. You can tell me that it's quite usual when you have an infected to have a small decrease in kidney function. It recovered in patients after clearing the virus in the resolving group, but it did not resolve in patients who developed a chronic hepatitis. We did several kidney biopsies in these patients, and the main histological pattern that we observed were proliferative glomerulonephritis and MPGN. They occurred with and without cryoglobulinemia for MPGN. Secondly, we observed some relapses of IgA nephropathy. We have several patients who developed, who have a relapse of IgA nephropathy at HAV infection. Interestingly, after the clearance of HEV, cryoglobulinemia disappeared in some patients, and we have a regression of the nephrotic syndrome. It's quite similar to what we had observed with HCV infection. In a rabbit model, they looked for the effect of HEV on the kidney, and they observed some interstitial lesions that have been observed in the rabbit kidneys. What about in the humans? Here are 2 case reports. The first one was a kidney transplant patient, the one above. The second one is an immunocompetent patient, and in both cases, they developed nephrotic syndrome, MPGN, cryoglobulinemia in one patient, no cryoglobulinemia in the second one, and in both cases, after the clearance of the virus, we have this clearance of the nephrotic syndrome, and kidney function recovered. This is a very recent study published in AGT a few weeks ago. They looked for HEV in tubular epithelial cells using PCR in the tissue, and thereafter they used immunofluorescence, RNA fish, and electron microscopy, and they were able to find HEV in the kidney. So we may wonder whether the kidney could be a reservoir for HEV, This has been already observed for HIV, so it's possible that HIV be in epithelial cells and could be responsible from some kidney injuries. So how can we manage patients with chronic HIV infection, solid organ transplantation, but mainly it's a kidney transplant patients? We had observed that among the 2/3 of patients who develop a chronic hepatitis, 1/3 of patients are cleared of the virus after the reduction of immunosuppression. I do not have time to go through what type of reduction of immunosuppression, especially it's the one targeting T cells, which means decreasing tacrolimus and all immunosuppressive targeting T cells. So this is the first line therapeutic option. The second option, because we have only 1/3 of the patient that can clear the virus, is to use an antiviral therapy. And this is a study that we have published several years ago, a multi-center retrospective study. And we found that ribavirin can be used in this setting alone at the median dose of 600 milligrams a day. It was adapted to the kidney function with a median empiric duration of 3 months, because we started with 3 months. And finally, the majority of the center used 3 months. And what we observed that after a first line therapy, nearly 78% of patients achieved SVR, and among relapsers, retreatment of some other patient allowed to increase the sustained virological response to 85%, which means 85% of the patients were completely cured. We did again the same study several years later. It's a European study, included 255 solid organ transplant patients with the same design. We had the same results, and overall, this SVR is 89%, nearly 90% of the patient can be completely cured of HIV. However, when we looked for the predictive factors of SVR, patients having a higher lymphocyte count are more able to clear the virus, quite expected. Those who require ribavirin dose reduction and blood transfusion, because as you know, ribavirin is eliminated by the kidney. In patients with impaired kidney function, it can be responsible for hemolytic anemia. So if you have to reduce the ribavirin dose, you have less SVR. And interestingly, we found that at the end of therapy at 3 months, patients who are negative in the blood, but who are still have detectable HIV RNA in the stool, had more likely risk of relapse after stopping ribavirin. This is why we suggested to modify and to optimize the duration of therapy according to the HIV fecal shedding. So if the patient has still HIV RNA in the stools, we give the ribavirin for a longer period, and in this case, you have a much higher rate of SVR. So what are the recommendations that to which I have participated to try to give how to manage its patients? So a patient with chronic HIV infection, if it's feasible, depending on the immunological status, we reduce the immunosuppression. If the patient achieves the clearance, it's perfect. Otherwise, we start ribavirin for 3 months, and we look for HIV RNA in the serum and the stools at the end of therapy. If it's negative in both, we can stop it. If it's still positive in the stools, we give it for a longer period. After stopping ribavirin, in case of a relapse, we give another course for a longer period, expecting to have negative HIV RNA. Unfortunately, there are some few patients in who, despite 1, 2, or 3 courses, they still remain viremic, and we do not have a lot of alternative therapies currently. In fact, we can use pegylated interferon that works very well, but it can be used only in liver transplant patient. We cannot use it in kidney transplant patient or in heart or pancreas because of the increased risk of acute rejection. Some other therapies have been used, sofosbuvir, zinc salt, diclozamide, etc. Unfortunately, all of them failed to obtain a sustained virological response. What about the treatment of non-chronic HIV infection, which means patients with acute on chronic? Should we give ribavirin? There's no robust data, no large series, and no control group. What about patients with only neurological manifestations? The effect of ribavirin is also uncertain because probably they will eliminate the virus rapidly and the manifestations are immune driven. In contrast, in patients with a kidney infection, a kidney manifestation, sorry, so MPGN or other, giving ribavirin will allow to rapidly improve the kidney function to obtain the clearance of the cryoglobulinemia. So in this setting, I think it's important to give antiviral treatment immediately, exactly what similarly to what we do with hepatitis C virus infection. So in summary, HIV infection, it's probably the most prevalent viral infection worldwide. It's mainly responsible for resolving hepatitis, so you do not know. To give you an idea, if you come to our area, among blood donors, 52% are seropositive, and all of them are absolutely not ill. You may have some fulminant hepatitis with in a pregnant woman, especially with genotype 1. For genotype 3, which is the genotype the most prevalent in our area in Europe and in the US, it can be responsible for chronic hepatitis among transplant patients and immunosuppressed patients. We may have some extrahepatic manifestation, like especially neurological and kidney injury. The treatment relies on the reduction of immunosuppression, and the first line antiviral therapy is ribavirin. In case it fails, you can use pegylated interferon, but only in liver transplant patients, not in our kidney patients. And thank you very much for your attention.
Thank you, Nassim. This was absolutely outstanding. It's a relatively new topic for us nephrologists. Of course, not for you, because you're working on it for a long while now. I have some very practical questions. The first is, when should we screen for hepatitis E? Is it only if we have liver enzymes that are going wrong? What is the strategy in a normal kidney transplant center who does not specifically work on hepatitis E? How should we manage this? Only screen if we have transaminases that go high? How should we do that?
Currently, in all patients with increased LFTs should be screened for HEV, and even before HCV and HBV. When you are doing the round in your VAD, you can see that the majority will check HCV and HBV, while the risk of transmission is really very low now, at least in Europe and in France. So we have to look for HEV first. What about patients with a kidney injury in our center, or patients who present with proteinuria, nephrotic syndrome, suspicion of MPGN or other? We screen for HEV. Should we do it in all patients, even if transaminases are absolutely normal? I say yes, even though the probability is low. However, we have some few patients in whom the transaminases is only 1.1, the upper limit of the normal, or 1.2. It's not very high, especially if the patients are immunosuppressed. So, and similarly, we did a study with for patients with neurological symptoms. We didn't do it in my center, we did it in the neurology center, and we looked for HEV in all patients presenting at the hospital for Guillain-Barré syndrome, encephalitis, and we found 5 or 6 patients who were positive for HEV RNA. So now, in our area, it's a high prevalence area, we look systematically for HEV RNA in kidney patients, neurological patients, and patients with increased LFTs.
And you told us, if I recall correctly, that MPGN related to cryoglobulinemia, when the hepatitis E went away, the cryo went down. So I guess the kidney symptoms could progressively resolve. But
Absolutely.
My question is, what about the membranous nephropathy? Because this could be immunologically a bit different. Do you think this could persist after? Because we have in kidney transplant some peculiar aspects of membranous nephropathy that could be related to DSAs, and I don't know how this could be. Should it ring a bell when we have membranous nephropathy? Always look for HEV. How do you see this?
The results are less clear with membranous nephropathy compared to MPGN. The first case of membranous nephropathy that I observed was a patient from Bordeaux. They had the case, and the patient, when he cleared the virus, proteinuria resolved and kidney function impaired. However, it was not the case in all patients with membranous nephropathy. I completely agree. This probably the mechanism of action is quite different. It may decrease in some patients, but not in all. In some cases, I'm wondering if it's not just a trigger for a disease without being really directly responsible. And this is exactly the same for IgA nephropathy. I have at least 5 or 6 patients who were grafted for IgA nephropathy without absolutely not any relapse. And when they have a HEV infection, they had a relapse of IgA nephropathy.
Okay.
It could be a trigger.
And I have another patient, another question. Are there some patients or some sorts of immunosuppressive treatments that are more prone to develop HEV? Because you said one of the strategies is to reduce T-cell targeted immunosuppressive therapies. So do you think some treatments we should be more careful in some sort of patients for this, or just the global level of immunosuppression?
Yeah, this is a good question. This is what we observed in our European study. Patients receiving tacrolimus were at higher risk not to be infected, but to evolve to chronic hepatitis. But for the infection, we did not observe any differences between immunosuppressive drugs. Probably the risk of infection is very high depending on the areas and the seroprevalence. The infectious dose of HEV, I'm not sure that it will modified by our immunosuppressive therapy, but the type of immunosuppression will modify the resolving hepatitis or the evolution to chronic hepatitis.
And you are in a region with a high prevalence of the disease, but you also have a high number of patients on belatacept. Are these patients prone to chronic? No, not really.
No, we did not observe. We are no, unfortunately, no. In the beginning, we had few patients who had belatacept and HEV infection, and we did not observe chronic hepatitis. It's not until now, even if the number of patients on belatacept is increasing, we did not observe a relationship between chronicity but belatacept. But probably you are right. It will be similar to H2 CMV or BKV. So, but we do not have sufficient patients with HEV and belatacept.
Okay, and going a bit further, since T-cell directed therapies are important in the transition from acute to chronic, they're also important in the pathophysiology. So you said to diagnose and to reach the disease, we need the RNA in the blood and in the stool, we need the serology. But what about T-cell, specific T-cells, ELISpot, for example? Do you think these diagnostic strategies could be useful or not?
We did it, and we also did gamma delta T cells. We looked for the expansion, and we found some correlations between the ELISpot response and the evolution to chronic hepatitis. But we did not use it to determine the duration of therapy. Similarly, that what had done with CMV. But you are absolutely right. Patient with no response to HEV at diagnosis will evolve to chronic hepatitis. And the first studies were done in Hanover with very, very nice studies showing that very low ELISpot, very low specific T-cell response associated with chronicity. And even less response to ribavirin.
Okay.
But I'm not sure that will be quite completely different to what we are observing with the lymphocyte count finally.
Yeah, okay. When we treat BK virus, there is an important part of the strategy, which is to put the immunosuppressive level a bit higher when the infection is resolving. Is it the same thing with HEV? Do we see the same trend in increasing the risk of cellular rejection after hepatitis E infection, or is it?
No, we did not observe absolutely no acute rejection after. Okay. The sole acute rejection that we had observed was in a liver transplant patient who have been in whom we had decreased the immunosuppression to obtain a clearance. And finally, we added PEG interferon in this patient. It was one of my first patients, and he had a very nice acute rejection. He completely recovered, but not in liver and kidney transplant patient. We did not observe any de novo DSA, any acute rejection, nothing.
Okay.
Because we cannot reduce so much in kidney transplant patient. So in the kidney transplant patient, we are targeting a tacrolimus trough level around 4 to 5. Usually, we do not stop MPA. but we stop it. We have to stop it sometimes under ribavirin because, as you know, ribavirin plus MMF increase the risk of anemia and hematological tolerance. So in this case, we stop MPA, but we have a tacrolimus between 4 to 5, so it's not so low, except in very high immunological risk patients. So in this case, we do not decrease it so much. We give ribavirin immediately.
Okay, thanks. Another question is, in one of your first tables, you showed that there was no pregnancy issue with the type 3 genotype. I was wondering, since it's not very well known and there are not so many pregnancies in kidney transplant patients, do you think there's really no issue for pregnancy with HEV in kidney transplant patients, or is
No,
it?
I don't think it's an issue because there are 1 or 2 or 3 papers of pregnancies with HEV infection, genotype 3 and 4. And we have a paper in press now with HEV HEV during pregnancy in a liver transplant patient with a huge HEV infection, and nothing happened.
Okay, great.
And even though we had HEV RNA in the baby when he born, and in the mother and in the placenta, but nothing happened. The baby is going very well.
That's good news then. Well, a last question, Gunnar, if you allow me. What about vaccine? Is there something in development? Should we consider this before kidney transplantation if it's ongoing? What's the scope?
Again, it's a very interesting question. The vaccine exists. There were 2 vaccines. The first one was developed by GSK. It was developed by GSK in Nepali army for the US soldiers when they were in Afghanistan. And when they left Afghanistan, they stopped the production of the vaccine. The second vaccine is a Chinese vaccine that works very well. There's one paper in the Lancet, nearly 100,000 patients. And the 5 years follow-up was published in the New England Journal of Medicine. It works very, very well. Unfortunately, it's not allowed to have it in France. And I participated to a meeting at the WHO in Geneva, and there are a lot of people around, and finally they do not trust the Chinese vaccine. I think they are a bit wrong. And when there were an earthquake in Nepal several years ago, I worked a little bit on this topic, and we were able to get vaccine for the refugees, and it was very good to have it because it was allowed them not to have HEV infection, especially genotype 1 and 2. The main problem for the genotype 1, of the reason that it was not accepted in Europe, that it was developed for mainly for genotype 1 and 2, and not genotype 3 and 4. But for the virologist, it's absolutely not a problem because there is only one serotype. Although we have 4 main genotypes, it's only one serotype. So the vaccine exists. We cannot use it. And it's only in China and some countries who accept the Chinese vaccine.
Okay, well, interesting. Once again, thank you very much. I learned a lot, Nassim. I send it over to Gunnar.
Yeah, and exactly the same for me. So I knew virtually nothing about hepatitis E before your talk and before screening some of your review papers. So there were so many papers that I wasn't able to read all of them, but I at least screened some of them. And I also have some rather basic questions. I do have basic questions because Dominique's questions were not basic questions, but transplant questions. So first question would be, would it be appropriate to say that genotype or serotype 1 behaves rather similar to hepatitis A, whereas serotypes 3 and 4 cannot really be compared to hepatitis A, but behave differently?
Absolutely. The genotype 1 is quite similar to HAV, at least for the mode of transmission, but it's probably more aggressive, and it's responsible for a higher mortality, especially in acute cases, more fulminant hepatitis compared to HAV infection. I completely agree that genotype 3 and 4 are completely different. And even for the neurologists, sometimes they said, this virus has the wrong name. It's not an hepatitis virus, it's a neurological virus.
And then I saw on one of your images that you had this dogs and cats as potential, well, sources. So you do lots of transplant patients, and surely all people come to you and ask you what to do with their pet dogs and pet cats. So do you see any risk here? Would you advise them to keep their pets, or would you be
No.
skeptical?
No. With the pets, it's really very, very low numbers. The main risk is deers, porks, and eating undercooked meat. The main message for the transplant patient is to avoid eating undercooked meat. The meat should be heated up to more than 70 degrees for at least 3 to 5 minutes to be sure that the virus is killed.
And the same actually is also true for us, I guess, because even we who do not receive immunosuppressive treatment should know really eat this kind of food. I know that people like this, I think it's called tartare, but
the tartare is usually beef, so it's not pork. But
correct.
if you eat the figatelli, which is the sausage from Corsica, this is one of the first papers. There are a large number of copies of HEV. We went once to the market in Toulouse and we bought nearly 18 different sausages, and 7 of them were HEV RNA positive.
So there's no issue with the tartare, but there are issues with different sausages, actually.
Absolutely. Especially for hunters, and this has been shown in Germany, hunters are at much higher risk of having HIV infection than non-hunters, because after killing a pork, they take out the liver, and sometimes they can eat it quite raw.
All right, that would be actually my next question. So I found some ideas that there may be rather great differences in prevalence between different European countries. And if I got it right, the UK has rather low prevalences or incidences, whereas in France they are higher. So does this refer to different ways of eating and cooking, or how should one explain that?
Yeah, it's probably it's because a different way of eating, and probably because for the nearly 90 to 95% of porks in all Europe are infected by HIV. But probably the mode of eating is quite different. In the UK, it depends in which part of the UK. If you are in the South UK, it's around 30%. So it's quite high. In Toulouse, in our area, it's around 52% in the blood donors. If you go nearby Marseille, it's around 35%. In the Netherlands, it's around 40%. So it depends, but it's still, I think, underdiagnosed. In Germany, it's around, I think, between 20-25%.
So because that's another question, you said that you would recommend to screen for hepatitis E in patients with membranous nephropathy and MPGN, particularly in high prevalence areas. But as the differences are apparently not so large, so you would also recommend to our colleagues in Austria and Switzerland and Germany also to screen for hepatitis E, at least in membranous NP and MPGN?
Absolutely. I think it should be part of the workup when a patient show up with MPGN or any nephrotic syndrome.
And then the combination of IgM antibodies and PCR.
Especially that even if the prevalence in the country is lower than in ours, you do not know what are people eating and which sausage are buying, and currently everything is traveling everywhere, so you can be infected even in a very low income country having just one sausage coming from my area, for example.
And that I learned when I went to medical school decades ago. If we see, so outside of nephrology, surely, if we see people with elevated liver enzymes, then the first test should be to check for hepatitis B and C and some other metabolic diseases. And if these tests are normal, if liver enzymes remain elevated, then we should go for second and third line tests. Would you recommend us to test, if we see a patient with elevated liver enzymes, to test hepatitis E at the same time when we test also B and C, or would you still stay with this two-step approach?
I say you have to check for hepatitis E before hepatitis C and B.
Okay.
So it's probably one of the most prevalent infection. There are a large number of suspected drug-induced liver injuries, and we looked for retrospectively for some serum, and nearly 10% are hepatitis E. So probably it should be done before hepatitis C and hepatitis B. I'll tell you, it depends also of the patient. If you are facing some patient coming from countries where the prevalence of HBV is quite high, you can start with HBV. But for people living in Europe, HEV should be screened before HCV and HBV.
Thank you. And then my last question before switching the mic back to France. So you showed us the guidelines from the EASL, so European Association for the Study of Liver, if I got it right. And these guidelines, just to double check, they refer both to kidney transplant patients as well as to liver transplant patients. Did I get it right?
They deal with all HEV infection in immunocompetent, and immunocompromised patient, and whatever the organ is transplanted. It's a review of all the management of HEV infection, whatever the population is.
Thank you.
You're welcome.
So that was fantastic. So now, Nassim, I think you're going to introduce for our colleagues from all over Europe, and especially from Germany, Switzerland, and Austria, your beautiful city, Toulouse.
So, what about my city? City is Toulouse, la ville rose, the pink city. So if you look, when you are arriving to Toulouse, it looks like this. You have the Garonne in the middle, and you have all the city around, and you can see that the colors are absolutely pink because it's pink bricks. So what can you visit if you are coming to Toulouse? First, you can go to the Bord de Garonne, which means that you can go nearby the river, that it's in the city. You can see on this part, this is the one of the old bridges in Toulouse, Pont Saint-Michel, and this is the other one, Pont Saint-Pierre, Pont des Catalans. And in this part is the old hospital. This was called La Grave. It was the church of the very old hospital. And on the other part, you have one of the, I show you later, a part of the hospital. So the evening, you can go have a drink and look for the river and to look for the Garonne. And it's a very nice place. And there are some places to be also in Toulouse. If you come to Toulouse, you have to go to see our main place, the Place du Capitole. This is the biggest place in our city. You have the opera, you have the mayor, you have everything here, and it's a very, very nice city. But there are some other very nice places in Toulouse. There's the place Saint-Pierre. You can see the church here, and you can bike around the Garonne. And you can go to another place, which is the place Wilson Place, Place Wilson, which is in the middle of the city, and you can see that everything is pink. And finally, when you are a bit tired, you can go to have a dinner and a nice beer in the Place Saint-Georges, which is again one of the 4 main places in Toulouse. You have also to visit some very nice places. This is what I told you earlier. This is the Capitole. If once you have from the Capitole, you have just to go some 2 minutes or 3 minutes, you arrive to the Basilique Saint-Cernin, which is a very, very nice church. You can continue to go to the Jacobin. It's a monastery, and it's also, that's a very nice place. You can visit it, and you can see the colors are, everything is pink. And this is our hospital. This is not, we are not working here. It's only the director of the hospital, the administrative part, and this was the old hospital several years ago, and it's a step of the Saint-Jacques de Compostelle trip. If you come to Toulouse, you have also to visit Airbus, because we are Airbus is produced mainly in Toulouse, and you can visit the museum where they are producing all and manufacturing all the Airbuses, and you can go to the Cité de l'Espace, which is the place where you have everything of what we can do that we do not have Elon Musk, but we have everything that has been done until now. And this is one Ariane that is in the middle of Toulouse. But you can also visit what's around Toulouse. You cannot stay in Toulouse because we are in Occitanie. This first, you can go for biking on the Canal du Midi. And this is a very nice place. You can go from Toulouse to Carcassonne, Narbonne, and continue up to all the Montpellier. You can go through the Canal du Midi biking, or otherwise you can take a boat and do it by boat. When you are doing this, you can arrive to the Carcassonne, and this is a very old city called Carcassonne. It's a very nice place to visit. If you go to the north of Toulouse, you can go to visit the Cathedral of Albi. It's a very old cathedral and very huge one, and in the middle of the city. And if you have some more time, you can continue and go to visit what is small town called Cordes-sur-Ciel. Cordes-sur-Ciel is a very nice and very small city, and you can have a 360 degrees view on all the area around. And finally, you can also do some sports, because you can do for doing some hikings in the Pyrenees, swimming or surfing. It's nearly 1 hour, 30 minutes to go to the Pyrenees, and you can go up to 3,000 meter high by hiking. And otherwise, you have only 1 hour, 15 minutes to go to the Mediterranean Sea. So you have some nice sand, you can swim. And if you like surfing, yeah, sometimes there are a lot of people surfing there. So you may spend a lot of good time here. So hopefully you will enjoy visiting Toulouse and the Occitanie region. It's a very nice place. And here are some other pictures of our city.
Thank you, Nassim, for this great lecture, for the cooking lessons, and for this overview of Toulouse. That was great. Thank you.
Thank you very much.